Thank you so much. Thanks, Eliza, and thanks, Pramila, for inviting me to be here. It's such a great honor for me to be here and talk about some of the things that I've done previously, and then talk a little bit about Critical Path Institute. So this is going to be first of a two-series presentation from CPath. Today, I'm going to talk about my own past research in autism, and then take some time to introduce Critical Path Institute and how CPath's way of doing things can accelerate innovation in ASD. And then subsequently, I believe in the next few weeks, one of my colleagues and good friends, Diane Stephenson, also from CPath, is going to talk in much greater detail about CPath and her previous experience working at CPath. The first study that I wanted to focus on is a series of sulforaphane clinical trials on which I have worked something close to 7 years with my mentor, Dr. Andrew Zimmerman. I've worked with him something like 10 years and did lots of research together, and some of the amazing work that we did. And I'm just going to share briefly some of the findings from those studies. So I was just saying that, this is like a cartoon that I never fail to. You've already heard me talk about it, but it's like people thinking about just one thing and then imagining that explains everything related to ASD. I mean, ASD is a lot more complicated than just thinking about just immune system, just mitochondria, just prenatal infections, or just synaptic issues, or just aging patients or parents, or just pesticides. It's probably a combination of all of these factors that probably play a big role in ASD. We know a lot about all the genetic mutations that are probably associated with ASD. In fact, there was a study a few years ago that there were something close to more than 800 genetic mutations related to ASD. Similarly, we also know a lot about how these genetic changes downstream impact the ultimate functional outcomes in ASD by leading to impairment in synaptic development and long-term, long-range neuronal connectivity. However, here's the thing, right? If you want to just focus on monogenic causes of ASD, you're going to certainly miss a lot of idiopathic cases. Our research had always been, for the past several years, focused on so-called idiopathic cases by focusing on these common metabolic pathways that translate these genetic changes to ultimate functional outcomes. And some of those metabolic pathways include things like neuroinflammation, mitochondrial dysfunction, redox metabolism, heat shock response. And because the way they function, they are probably going to be present in like most or all of the patients with autism. And that gives you quite a big kind of a cohort or a field to work on. And this is basically where our sulforaphane research and clinical trials came in. So I'm going to return back to our study drug, sulforaphane, a little bit, but our first clue that came to us that led us to use sulforaphane was from observations in the clinic since decades and many years, and then it was published formally in pediatrics in 2007. And those were related to behaviors associated with fever in children with ASD. It's been known anecdotally and then finally proven in this paper that when many children with ASD, they have a fever, their symptoms tend to temporarily improve. They would have better eye contact, they were less irritable. Some of them even had better improved language. This is really temporary. So, when the fever goes down, the symptoms would tend to come back again. We wanted to look at what were the reasons behind that, we were looking what causes, right? And the ultimate idea was that if we know that fever improves symptoms of autism, is there a way to pharmautically induce similar kind of changes that fever does? So basically use that mechanism as kind of a treatment for autism. And then our second clue came from the work of one of our collaborators at Johns Hopkins, Kirby Smith. We worked with him for a very long period of time, and he discovered that there are many small molecules which activate stress proteome. And that stress proteome is basically something that happens in the cells and that enables the cells to protect themselves against various different type of insults. The interesting thing is this, the fever in part also activates a similar type of stress proteome and stress response as some of those molecules that our collaborator at Johns Hopkins was studying. One of the molecules, small molecules that was identified in this study that I put in previously was sulforaphane. I mean, I really consider sulforaphane as a very special small molecule. It's an isothiocyanate. It's present in very high concentration naturally in broccoli sprouts. It has got quite a few mechanisms of action, and some of those are similar mechanisms that happen in the body as that happens in fever. Like it activates heat shock response. In addition to heat shock response, it has impacts on redox metabolism. It impacts mitochondrial dysfunction. There's been tons and tons of studies that have been done that shows that sulforaphane has all of these impacts on neuroinflammation, immune dysregulation. It has impacts on synaptic dysfunction too. So basically, we felt that sulforaphane in part causes pretty much the same intercellular changes as that of fever. So knowing what sulforaphane does, in 2011 at Lurie Center for Autism, Massachusetts General Hospital, we decided to do a preliminary pilot study of sulforaphane in 44 adolescents and young adults with autism, moderate to severe autism. And we found that as compared to placebo, patients on sulforaphane were doing significantly better after 18 weeks of treatment. As you can see, the first graph, the bar that's label B, is the changes in total ABC score. At 18 weeks, you can see the ABC score was so much better, more improved, decreased as compared to placebo patients. Similarly, we had similar changes in social responsiveness scale. And similar was the participants patients who were improved or very much improved on the Oasis scale. I'll explain what Oasis scale is in the upcoming slides, but it's basically a CGI scale that has been adopted to be used in autism. After getting a really good signal in older patients, we decided to then do a slightly more complex trial in younger children. And this was the one we did at University of Massachusetts Medical School. This was a double-blind, placebo-controlled, single-arm crossover clinical trial, phase 2 study in 50 children's, young boys and girls, 3 to 12 years of age with autism. So the treatment duration was 13 weeks. First 15 weeks was double-blind, placebo-controlled, 1-to-1 randomized sulforaphane or placebo, and then the next 15 weeks were open-label, single-arm crossover. All the patients who were in placebo were basically started to give active drug, and we did it this way because we wanted to have every possible child to have a possibility to receive the actual drug. Our primary outcome measure was the Oasis scale. As I was mentioning, Oasis is basically a CGI scale that has been modified to be used in autism. It was developed by Ohio University, some autism researchers in Ohio University. In addition to the overall level of improvement that you use in CGI, it also asks questions specific to some of the most important domains of autism, such as social interaction, apparent behaviors, and so on and so forth. One thing that was different in here was that we used a drug that was a bit different from the original study. So in comparison to pure sulforaphane, we used a precursor of sulforaphane, that is glucoraphanin, and it was combined with an enzyme known as myrosinase that when it gets in contact with water, it'll in vivo convert glucoraphanin to sulforaphane. And there were two reasons. One was pure sulforaphane is very unstable at room temperature. You have to keep it ideally at minus 80 degrees, or if possible in a regular home freezer at minus 20. That was one of the reasons. Second was that the lab that manufactured sulforaphane for us had an unfortunate accident, and their facilities basically caught fire, and they were unable to make enough sulforaphane to be used in this study. So we really had to settle to using this commercially available combination of glucoraphanin plus myrosinase. Then we did it after the clinical trial finished. We did the analysis, and we found that at the end of the study, double-blind phase, this is like overall analysis, that 17% of the patients had improved on Oasis, and then once you go to open label phase, we saw that the response had more than doubled to approximately 52%. And then at washout phase, when they had stopped taking the drug for approximately 6 weeks, the improvement tended to go down to baseline. These are some of the parent-reported outcomes. We saw that there was a significant decline in overall total ABC score at 15 weeks, but then at 22 and 30 weeks, patients, they tended to catch up. The placebo patients, when they were on active drug, they tended to catch up, and there was no significant difference between placebo and sulforaphane patients at 30 weeks. At no point during the study, SRS score differed between placebo and active drug sulforaphane. This was some of the mitochondrial function analysis that we did. At each visit, when patients came in, we collected whole blood and isolated PBMCs, and then one of our collaborators, Richard Fry, who I believe has either spoken or is slated to speak, and I'm pretty sure most of you would have already known him. He did some seahorse assays for us, and we found that patients who were on sulforaphane had increase in ATP linked respiration. This graph A that you see there, there was no such change in placebo patients. One of the things that we see here is that mitochondrial function was measured in peripheral blood cells. Not exactly sure how they would correlate to neuronal function, but we certainly did not have any mechanism to measure mitochondrial function in neurons, obviously, for obvious reasons. But this was the best that we can do. But still, you can see that the changes were clearly there. These are some of the biomarkers that we did. If you look at, there was quite a bit of correlation between sulforaphane placebo and patients who improved on ABC total score. So we did the graphs two ways. One is sulforaphane versus placebo at 15 weeks, the first graph. Second was more than 20% improvement, clinical improvement on ABC total score at 15 weeks. You can see one of the striking findings is that patients who were on sulforaphane and patients who clinically improved had much greater improvement in decline in gene expression related to TNF alpha in both cases. There were some changes in interleukin 6 in sulforaphane patients here, HO1, heme oxygenase in sulforaphane patients. Similarly, there were similar findings in patients who had clinically improved also. But one common factor in both of them were that TNF alpha was decreased in both. Talking about safety, it was pretty clear that for the most part, sulforaphane was very well tolerated, not many serious side effects, no serious adverse effects, but there were some cases of non-compliance, some cases of diarrhea, GE reflux. There was one patient who had a single case of seizures during the first month after discontinuation, but again, unable to determine whether it was due to the drug or whether because autistic patients already have increased incidences of seizure and epilepsy. So yeah, the idea was that it was pretty safe, well tolerated. Side effects were all transient and self-limiting. So in summary, we felt that sulforaphane is safe and effective in at least 30% of children with ASD, at least in the cohort that we studied. It's a bit different from our previous study in older patients, probably maybe because this age range is different. Second is the drug was different, even though we tried to do our best in terms of adjusting the dose by bioavailability because we had the precursor product plus enzyme this time. But again, it does indicate a level of uncertainty that we really cannot ameliorate. Maybe if someone would like to do future studies, they would have to find sources of pure sulforaphane. The only one that we know is available in France, and importing it from France is like really, really difficult. Anyways, so this is about sulforaphane clinical trial. Then a very brief introduction about mitochondrial function and regression. And I had already shown you some of the mitochondrial function studies in sulforaphane. We did another clinical study, observational study, in which we compared mitochondrial function using seahorse assays, using the same lab that did our sulforaphane assays from PBMCs. there were 3 cohorts, age matched. All 3 of them were age matched: patients of autism with regression, patient of autism without regression, and neurotypical normally developing controls. And one of the striking features we saw was that maximal OCR, maximal respiratory capacity of mitochondria, was much higher in patients who had regression as compared to patients to controls or ASD patients with no regression. Same assays, Seahorse assay that we used here. But again, the thing is that these mitochondrial function in peripheral blood cells. How well they would correlate to neuronal function, it's an open question. But the findings certainly are very striking. And they lend credence to some of the previous research that there is certainly some degree of mitochondrial dysfunction in autism. Anyways, that's enough about talking about my autism research. Shifting gears to a little bit about Critical Path Institute. I'm going to talk only briefly. My colleague Diane is going to talk about it in much greater detail. So CPath was formed in 2005 as a result of Critical Path initiative by the FDA. The ultimate goal was to foster development of new evaluation tools to inform medical product development. It acts as a public-private partnership, as a neutral third party between the regulators and the researchers, whether those researchers are industry researchers or whether these are academic researchers. So pretty much every single consortia consists people from industry, from academic researchers, from patient advocacy groups, and from regulators. And all of these people interact with each other, and CPath acts as a pre-competitive neutral ground. And one of the good things with this design is that it enables FDA, EMA, or basically any regulatory participation in developing new methods to assess the safety and efficacy of medical products. We work in pretty much lots of fields, and all of these are the fields that have a great deal of unmet need. As you can see that autism is not in there. That was one of the reasons why I'm talking about it. And I'll go over some of the things that CPath does, and then maybe leave it an open question that maybe some of the things that CPath does can actually help in a similar manner for autism too. One of the core competencies at CPath is data sharing and aggregation. We collect data from multiple studies, multiple clinical trials from all over the world, from whether it is academic or industry-sponsored clinical research or clinical trials. This is the core competency for Critical Path Institute, data science and quantitative medicine. Pretty much every single consortium at CPath works in this fashion. We collect data from different sources, whether it is academic, industry, clinical trials, natural history data, biomarkers, translation data, genetic data, so on and so forth. And all of that data is combined by CPath's Data Collaboration Center into a central data vault, where it is curated, standardized, and converted into one unified database. It is basically akin to a very, very large meta-analysis, patient-level meta-analysis, if you would like to compare it with something like that, right? And then the quantitative medicine division within CPath will take out the subsets of that data and work with our collaborators and researchers in taking into consideration the feedback that we will get from our regulatory colleagues such as FDA, and then come up with actionable drug development solutions, such as some of the clinical trial simulation tools that have been come up as a result of this, better biomarkers, better enrichment criteria for clinical trials. In the end, the ultimate goal is to do expedite drug development. This is our agenda for the next 5 years in CPath. We would like to play a major role in pediatric and drug and device development, and that is probably how autism comes into the picture also. I'm going to talk very briefly about the CPPS Parkinsons studies. My colleague Diane is going to talk about it in much greater detail, but CPP, Critical Path for Parkinsons, has acquired data from something close to more than 10,000 patients around the world. They were all either industry or academic sponsored clinical trials or observational studies. They've had quite a few successes based on analysis of this aggregated database. For example, they had regulatory, by regulatory, I mean FDA endorsement of prognostic imaging biomarkers for use in Parkinson's disease trials targeting early motor Parkinson's disease. Then they made a clinical trial simulator that is openly available for use in trial design. Anyone can use it. And then as a result of the data that they collected, they were able to make a Parkinson's disease, a quantitative disease progression model in clearly genetically defined subjects. All of these were published in major journals, and I'm happy to send you the list of these articles if you would like to be, if you are interested in this. One interesting feature that I would like to point out here, specifically for Parkinson's, because it's also relevant in autism, is a lot of data was academic data. Similar to lots of clinical trials that go on in autism, they are academic clinical trials. So just because ASD has academic studies should not probably be a hindrance in terms of CPath playing a major role in there. Again, going to leave it an open question whether the similar type of core competencies, data science related core competencies in autism can play a major, CPath can play a major role in accelerating drug development in autism. I personally feel it certainly can. We just would need a lot of collaboration from all the researchers once we have some autism-related program going on at CPath to share their data with us so we can come up with a unified clinical database. Other possibilities are that we can make a drug disease trial model and simulation to come up with better regulatory qualified biomarkers for use in clinical trials and so on and so forth. Possibilities are really endless here. So I'm going to stop now.
Thank you,
because
Dr.
I'm running
Singh.
out of time. Yes, thank you.
Yes, we have a few questions for you that I would love to have a chance for you to answer. So thank you so much for this really insightful presentation. I agree with that. We are definitely looking forward to the future in developments and excited that you are part of that journey. There is a couple of questions here. Let's see. So this is about dosage of the sulforaphane product. This one particular participant is giving the Prostaphane brand from France. And the dosage, I guess this is really a general dosage question. You know, how would you dose it? Would you dose it daily? Would you pulse it? You know, or you know, ramp up the dose?
Yeah, I think, you know, a 10 milligram stabilized sulforaphane seems to be enough, but again, I don't know what her weight is. It depends on the body weight. We certainly would prefer to do it, give it daily rather than every 3 days. Every 3 days is probably not enough. 10 milligrams should be good, but again, I really do not know what was the dosage. What was the body weight of that? It depends on the body weight. It is something like 5 milligrams for a patient who is 25 kgs weight. But again, you know, it depends on the weight. Maybe you can ask her to get in touch with me offline, and I'll be happy to provide her with some more information.
Dr. Singh, I'm curious. I mean, there was such a good safety profile for sulforaphane. Did you see any upper limits of dosages where?
Well, I mean, if you would like to overdose it, patients would probably tend to become hyperactive and irritable because its ultimate effect is to act as a stimulant for the brain. So I can see that it said that her weight is 24 kgs. So 5 milligrams every day would probably be a good dose there. 10 milligrams every 3 days is probably not enough.
Okay. And then you had mentioned, so there was a question about sulforaphane is shown to increase gene expression in some pathways. In this regard, is it best to give it continually or pulse it? And what is the duration?
We used to give it continually because sulforaphane has a half-life of something like 8 hours or 9 hours or something like that. There were some pharmacokinetic studies done in that manner. So giving it continuously would be best rather than giving it. Certainly every day would be better, or maybe twice a day would be better. That is probably not preferred because if you give it in the evening, it'll impact patient sleep because of its stimulant effect.